Hi, I'm Gary White with Channel 6, Central Kentucky Television. I'm here with Dr. Johnny Isaacs with Isaacs and Isaacs General Dentistry on Bobolink Drive in Springfield. And today we're here for our monthly dental segment, and we're going to talk about something that everybody loves, extractions.
Oh, no. Oh, no.
There are different kinds of extractions, right?
Yes, and in this area, this rural area, we seem to do quite a bit of extractions. We see, on the average, I'd say anywhere from 5 to 10 extractions per day. So it's not uncommon to do that. I mean, we might go a day where we don't do any, but that's rare. And then some day we might do 30 to 50. You just never know exactly what you're going to do. And there are varying degrees of extractions. Not all extractions are the same. Essentially you have primary teeth, which are baby teeth. They're easy to get out unless they're ankylosed sometimes. But they're not very difficult, but you still have to go through the same.
What's ankylosed?
Ankylosed, good question. Ankylosed is a term that dentists use when part of the tooth and the bone are actually fused together. When they're fused together, that makes them a little more difficult to get out. And it happens on permanent teeth too. And I'll go over that here in just a second too. But ankylosed means that the bone and the teeth are going together and they're not exfoliating. Where the baby teeth are designed to exfoliate, designed to fall out, and if because of a tooth is pushing underneath of it. So if a tooth is pushing underneath of it and it's not coming out, you can see it on X-ray that it's stuck in the bone or ankylosed, and then it's got to be taken out. But what I was going to talk about were simple extractions, and that's the term that we use, simple extractions versus a surgical extraction, which would be a little more complex. So, and that's what we call them. We call them simple extractions and versus surgical. And there are varying degrees of surgical. But I'm going to speak mainly about general dentistry and what we do and how we differentiate between a simple versus a surgical.
Okay.
And people come in generally with a toothache. If their tooth is hurting, and we call it non-restorable. If you can't fix it, then we have to get it out. Now, some people, even though it is restorable, sometimes we take them out anyway, just because they can be expensive, or the fear of it, or the fear of a root canal. There's that word again. I vow never to say that the R word, the root canal word. But you can generally, if you have a toothache, you need either a root canal done or take the tooth out. And being in this area, we take out a lot of teeth. This morning, I've probably taken out 4 or 5 teeth already. So here it is. It's about noon, I guess. But we do quite a bit. And on a simple extraction, that is where the tooth, let me show it up here. The tooth is embedded in the bone here. The teeth sit down into what we call a socket. But around that socket are about 1,000 ligaments that hold the tooth in there, and what the PDL, which is the periodontal ligament, all the way around it. And there's about 1,000 of them that hold it in there. So when you do it, when we take a tooth out, we come to, we're going to speak on the mandibular or the lower jaw first, and there's the nerve right here. This is called the inferior alveolar nerve. And this is the one you want to block. We come in here with our Novocaine. We give a little bit of medicine right over top of it and go right to this little nerve and block that nerve. And when you block that nerve, we want the whole jaw to be dead. It numbs the whole jaw it gets half your tongue, and it gets from the midline all the way back. And then we'll give a little bit right beside there to get the tissue numb, just a pinch of that down there. So whenever we do a simple extraction, we get in and we take an instrument called an elevator, and we'll get in between the 2 teeth, if there's a tooth on either side of it. We'll kind of prise it up there. We just kind of nothing fancy. We're just kind of working it around just like you would if you had a stump in the ground, or you try to get leverage on it and just kind of push it up and down. Now the patient is numb. They're not feeling anything. It is a little creepy because we're pushing pretty hard on you, and you kind of feel things moving, and that's kind of the creepiness. Pain, not so much. If you do have pain when we're doing that, just tell the dentist, and we'll give you a little bit more Novocaine, and that generally works. But we put it in there, we prise it across, then we have what are called forceps that we put over top of it, and we just kind of wiggle it left and right, just put a little pressure to it backwards and forwards, and then gently it comes out. That's a simple extraction.
Okay.
Sometimes simple extractions is just like I say, a term we use. Then we go to the surgical extractions. When would we do a surgical extraction? Well, when the simple extraction didn't work. If we can't get it out, like that, well, we go to a surgical extraction technique, and what that involves is anytime we take away bone, anytime we have to get in there and we remove the bone that's holding the tooth in there, that's the definition is a surgical extraction. And sometimes we'll go up to the one behind the tooth, sometimes the one in front of it, and we'll get a scalpel with a blade in it, and we will make a little incision there behind the tooth and in front of the tooth, and lay a flap. When we say lay a flap, it's like a little envelope that we kind of peel back, and then we can get down there and see the bone. Once you see the bone, then you can. There are several different techniques. The one I generally use is I'll get a handpiece. It's a surgical handpiece, a sterilized handpiece with a sterilized burr, and we'll actually get in there and cut away the bone on either side. And then after we do that, then we get in there and go back to the simple technique. Just go back and forth, rock it out, rock it, come and bring it out the side. Now, if you can't do that and it's still locked in the bone, then we have to separate the teeth. And this technique, if you're getting in there and this is sitting in here thusly like that, if you can't get the tooth out that way, then there's a little furcation in between these teeth. So you go in between here and make a little incision in between it, and once you cut these in two, then you can take them out as if they're two teeth as a simple extraction. So essentially what you're doing on a surgical extraction, you're getting it loose so that you can take it out with a surgical extraction. Simple extraction.
Huh.
Clear as mud, right?
So
hope everybody understood that.
Yeah, so why though did you extract the teeth?
Why do you take it out?
Yeah.
Because they're non-restorable. You can't fix them. Now, so there's several different reasons. It could be the pains. They can't deal with the pain anymore.
Because the cavity?
Because the cavity is in the nerve. Or you have gum disease. You'll have periodontal disease, which the old term used to be pyorrhea. People used to call it pyorrhea. We don't call it that anymore. It's periodontal disease. And periodontal disease, by definition, means it's destroying bone. So teeth that the bone has been destroyed, they're a little easier to get out because essentially the bacteria worked around it and got it loose for us. So if teeth are loose, generally you don't need to have them surgically removed or cut out. And the reason why I'm having this topic today, in the last week we've cut out several teeth. Every day we've been running that handpiece that sterilized the surgical handpiece a lot. So that's why I thought it'd be a good time to do this. So we've been cutting out a lot of teeth. And I've had patients say, well, I didn't know you cut out teeth here. Well, most dentists do. What we don't do here in a general dentist office is we don't put you to sleep. The oral surgeons generally do that. There's a nurse that comes in. You have to have an RN there in the office in order to do that, to administer the analgesic drugs. Right. So then once that's done, then the surgeon will just take it out. Maybe simple extraction, but a lot of times the surgeons go ahead and we'll cut them out with a surgical extraction. Now the surgeons they get some pretty tough stuff, pretty tough extractions to do. And to me, I look at it. It's my job to take the easy ones, actually do the easy extractions and the ones that I can get to, because it's tough to get an appointment to see an oral surgeon a lot of times. And if he's bogged down by doing something routine, something simple, we're not utilizing the surgeon the way he's meant to be used. So I like to try to hold the surgeon back for something that we're really going to need him for. Because sometimes it might take a month to get into a surgeon in this area, and then if the patient's got a problem or they're in a lot of pain, they can't wait a month. So I end up doing it here. So that's why I try not to clog it up with simple extractions. So after you do that, everybody wants to know how much pain are you going to have. Well, are you going to be in pain after a surgical extraction? Not any more than you would for a regular extraction, a simple extraction, just because the same mechanisms are involved. We tend to call it discomfort. We give an antibiotic for that to try to keep the bacteria levels down, and also an analgesic. We'll use the opioids that you hear about in the news. We use some Narco, which is hydrocodone, or oxycodone, which is We use Percocet sometimes like that, so that's not uncommon at all to use it. But we since the opioid crisis, we have been minimizing how much anesthetic we do, because we are being graded, we are being watched how much we're giving out, and the patients are too. So and it's good. It's cut down a lot on a lot of the abuse, which is great.
Absolutely.
Now, after you cut a tooth out, if you cut a tooth out, you are increasing the chances of getting what's called a dry socket. A dry socket is an infection in the bone. I think we talked about it before. The term that dentists use it's called an alveolar osteitis, or layman's term, dry socket. Why was it a dry socket? Years ago, somebody looked in there and it looked dry to them, and it just got that term stuck. So it has nothing to do with how dry it is. Somebody just looked at it and described it that way. So we treat a dry socket with antibiotics and pain medicine. We'll bring them back maybe every day. I've got 2 people coming back this afternoon that we're going to see, that we've been seeing every day for the last few days, to change the dressing on it. And that's kind of what spurred this conversation we're having right now. We were just doing a lot of that, and they all want to know, what should I've done, or what can I do to prevent a dry socket? The answer is not really anything. If you're a smoker, your chances increase greatly. So I tell people, and then they always tell me, well, I won't smoke today. Well, number one, if you're addicted to cigarettes, and that's what you're going to do to feel good, you're going to have to probably smoke, or you can't go through withdrawals on nicotine withdrawal for that, and we don't really expect you to. You're already miserable, so why be miserable with that? So go ahead and do it. But the problem is, it's the smoking you do before, so you really can't gauge that. You would have had to quit months before in order to prevent the dry socket. So it's really it's the carcinogens and the tar that's in the cigarettes that are impregnated into the tissue that cause the dry socket. So it's really smokers, not smoking. If you never smoked a cigarette and you got a tooth taken out, and you smoked a pack that night after you took it out, you wouldn't get a dry socket, because it's not down in that tissue. So it's really not the smoking, it's the smokers.
Okay.
So I hope that clarifies that. So we get that a lot. And here in this area, we have many smokers. So that's
a dry socket.
Back to life around here. We keep that dry socket paste very handy.
Okay. Well, that's some information on extractions, and it's not something to be fearful of,
Yeah,
right?
it's not bad. Do it every day. Matter of fact, there's somebody numbed up right now that I just finished with, and we're going to change his dressing. He'll be out of here.
Okay. Well, let's get back to it.
There you
So
go.
I've been talking with Dr. Johnny Isaacs with Isaacs and Isaacs General Dentistry on Bobolink Drive in Springfield. And if you are looking for a dentist, give Dr. Isaacs a call. And what's the phone number?
Okay, 859-336-7680.
Great. This has been Gary White with Channel 6, Central Kentucky Television.